Okay, Beth, are you still here? Because it looked like you left.
Yeah, I'm here now. For some reason, it kicked me out. So yes, I'm back.
Oh, okay. Okay, that's good. All right, so I just started recording again. We're going to start with antibiotics. So let me just see what my screen is, because sometimes it's open on things that aren't shareable. Here we go. Oh, thanks. I will make note of that, Ryan. So I have that. Kill. Okay. So the only people I don't have are Nicole and Emily and Shimon. So if you guys are here, please say so I can give you credit. Okay, antibiotics. Oop. Emily, I'm sorry. I got you now. And then I hear, okay. All right. Well, that's exciting. And then if Caitlin or Shimon show up, they should announce themselves. Oh, probably it might not show if I haven't logged on yet or rejoined the call. I'm not sure if it will or not. So, okay, so antibiotics. Let me share the screen again. I am recording. So by and large, this is our largest group of medications for infection that we'll talk about. So we have to keep them organized in our minds that the overall therapeutic class, what we're doing is trying to, our antibiotics, we're trying to rid the body of a bacterial infection. This mechanism of action or therapeutic class are antibiotics that inhibit cell wall synthesis in some way, damage the cell wall. So there are several families of antibiotics in this class that in some way change cell wall synthesis or damage the cell wall. So each family has a name, and then each family has a prototype drug, which is the drug you'll see on that exam. So here's our first family of antibiotics that damage or change cell wall synthesis, and that's penicillin. Penicillin is the family, all of the medications in this family end with "-cillin", so that's helpful in case it's a medication that you don't recognize. Penicillin G was really the first penicillin, but it's not prescribed much at all anymore because of lots of resistance. The one that you will see prescribed quite a bit is amoxicillin, and the other is amoxicillin with the addition of clavulanate or clavulanic acid. The brand name for that combo medication is Augmentin. So clavulanate is not an antibiotic, it's an additive that helps this medication work better, which I will now explain. So the way that amoxicillin and penicillins work is that within their chemical structure, they have something called a beta-lactam ring. So we usually don't have to memorize the particular chemical structures, but in this particular case, this is what's special about penicillin, because it's this thing that sort of acts like a cleaver to cut cell walls and allowing and weakening that bacteria so it can kill it. So this is the special innovation of penicillins. The way that some bacteria have gotten around this chemical innovation is to create something called beta-lactamase. Beta-lactamase is created by resistant bacteria, and that enzyme destroys the beta-lactam ring, which means the penicillin will no longer be effective. So what chemists did, or people that work in drug companies, was to add clavulanate or clavulanic acid, because clavulanic acid gets rid of beta-lactamase. So it increases the use of amoxicillin because it gets rid of some of the resistance to amoxicillin. So penicillins have the chemical structure of a beta-lactam ring, which is what allows them to enter the bacteria cell and to kill the bacteria. Resistant bacteria have created an enzyme called beta-lactamase, which destroys the beta-lactam ring so that that medication doesn't work anymore. And the addition of clavulanate or clavulanic acid to amoxicillin helps to get around that resistance by inhibiting or removing beta-lactamase. So that's the key difference between them. You'll still see amoxicillin prescribed on its own, especially sometimes in children. That's like the pink suspension that you might remember when you were a kid that tasted pretty good and was in the refrigerator. But amoxicillin on its own is not often used in adults because as time goes on, generally people develop resistance. Bubblegum, yes, it did taste pretty good actually, as I recall. So some drugs, and that's what we talked about, diarrhea, nausea, superinfections, allergy, those are all very, very common with penicillin, just like we talked about for all antibiotics. It's best to give penicillin at the beginning of a meal on an empty stomach. However, we know that not everybody can tolerate that. The recommendation of our textbook is to, if you're trying to get an infant or a small child to take the medication and they're resistant, it's best to place it on their tongue, or you could mix with a small amount of juice or formula to get them to get it down. You're not supposed to do what I usually did, which was pretty much tackle my child and squirt it in there. Caution, it doesn't cause renal disease, but if somebody has kidney issues, the dose has to be adjusted. Another big thing here, this is true of several antibiotics, and usually there could be one or two people that, not knowing this, have had a child because of this, but antibiotics, especially penicillin, can decrease the effectiveness of oral contraceptives. So if the provider doesn't tell the patient that their oral contraceptives might not be as effective for the rest of the month, sometimes people can become pregnant. So that's a very important thing to tell people. Okay, so we're antibiotics. Mechanism action is damage to cell wall, change in cell wall synthesis. Our first family was penicillin. Our prototype med was amoxicillin, and amoxicillin with clavulanate. Now our next family are the cephalosporins. There are a ton of cephalosporins. There's 5 generations, each trying to decrease resistance and increase the use for a wider range of types of bacteria. There is a similar chemical structure between cephalosporins and penicillins, in that there's the beta-lactam ring. And so for that reason, a cross-allergy exists between cephalosporins and penicillins. It's much, much higher if the allergy actually causes difficulty breathing and anaphylaxis. Usually with rashes, the patient will probably be okay, but there is a risk, and so sometimes it's just avoided just to be safe. Our most cephalosporins begin with CEF. Our prototypes are cephalaxin, which is Keflex, and cefotetan, which is not prescribed very often. It can be given in the hospital because it's really good for meningitis. That one really penetrates the blood-brain barrier well. So same side effects. Got to worry about the GI stuff, allergies. You have to worry about superinfections. If we're giving this IV, it can cause a thrombophlebitis. Does anyone remember what a thrombophlebitis is? what that is an oh, Scott. I don't want to take away anyone's. Not entirely. So it's not a blood clot, but it certainly puts them at risk for a blood clot. What it is an inflammation of the vein itself. So, and it could become a clot that becomes infected. That's the range of things that can occur. Sometimes you'll notice that this is a problem because the IV site will have like a red streak extending from it. So if that occurs, it doesn't mean that the patient is allergic to the medication or they can't take the medication. What it means is that it's irritating the vein, and so the IV should be moved. Sometimes that's more common if the IV medication is going in too fast. But the rates are figured out for you based on that information. So you just have to watch the IV site to be sure it doesn't get irritated. Cefotetan is the only cephalosporin that can increase the risk of bleeding. And just like penicillin, it doesn't cause kidney disease, but we might have to adjust the dose related to kidney disease. It might have to be decreased to decrease the risk of toxicity. We said that all antibiotics, we should decrease or not use alcohol at all because it can cause dehydration, which we don't want when somebody is sick. But for some people or some antibiotics, you can get a reaction called the disulfiram reaction. So I just want to explain that a little bit further. Disulfiram is a medication, actually. Its brand name is Antibiotics, and it was used, it's sometimes still used, but not as often. It's used as a deterrent to alcoholism or alcohol use, because if you take this pill, disulfiram, if you take Antibiotics and then drink alcohol, you will feel sick. You will have those symptoms: nausea, vomiting, headache, and a potential drop in your blood pressure. So it's a way to not drink so you don't want to feel sick. There's obviously a way around that. I mean, if you want to keep drinking but don't want to feel sick, you can just stop taking that medicine. But there are some medicines that are chemically similar enough to disulfiram or to Antibiotics that they will cause a similar symptoms when combined with alcohol. And cephalosporins, specifically cefotetan, but cephalosporins can also increase the risk of the patient experiencing that disulfiram reaction. And so that's another reason for these patients to avoid alcohol. Okay, still in antibiotics, changing cell wall synthesis or destroying the cell wall. We talked about penicillins family with the prototype is amoxicillin, and clavulanate. Talked about the cephalosporin family. The prototypes were cephalaxin and cefotetan. Now we're talking about the next family, which is monobactam, and the prototype is azactam. This is our first medication that is a narrow spectrum, meaning it's specifically targeted to certain types of bacteria. It's not a broad spectrum that can be used for all types of bacteria. Typically, I've seen this medication given in the IV format, and it's usually the hospitalized patient that would receive this medicine for severe infections. Again, we have the usual things that we have to worry about: superinfections, GI symptoms. This particular medicine adds with it an increase in abdominal pain above and beyond the usual stuff. Neurotoxicity like seizures, respiratory symptoms kind of similar to asthma, like a bronchospasm type feeling, which would be separate from like a usual allergy, but it could be a reason for the person to not take the medication anymore. IV thrombophlebitis, just like with the cephalosporins, so we have to watch the IV site. this medication is also incompatible with lots of other IV medicines. So you have to be careful when you're giving multiple IV medications. If there is an incompatibility, then they can never be in the same tube at any point in time, because either it could decrease the effectiveness of one or both of the medicines, or it could actually cause one or both of the medicines to precipitate or become like sand in the tubing, which increases the risk of an embolus. So sometimes, I don't know how many people have gotten to give IV medications, especially since not many people are allowed in the hospital, but sometimes you'll have a main IV bag that's your like maintenance fluid, like normal saline, and occasionally you'll hang like a secondary bag, not a little secondary, and maybe this is one antibiotic that the patient is on. Maybe they're on a cephalosporin, and so when that medication goes in, it's sharing this tube and that medication is in this tube, and then it'll go down this tube when it's infusing. If I'm supposed to give Azactam, sometimes what people do is they'll back flush the tubing, so they'll hold this below so that the tubing is flushed with saline, which is a way to help prevent incompatibility. Or you could just use a separate tube. Like when I'm giving Azactam, it's going to have its own tube, so I don't have to worry about it. So those are just things that you'll have to work with when you're the nurse giving multiple types of antibiotics, especially if there's any incompatibilities. Or maybe this solution that the patient gets all the time isn't compatible with the medicine, then you would have to run the antibiotic in a separate IV. Otherwise, you have to hold this medicine. So it can get complicated. All right, so we're working through penicillin, cephalosporins, monobactams. Now we're carbapenems. Carbapenems are the strongest antibiotics that we have, the widest spectrum and the strongest available. This is typically given IV as an inpatient. The patient is very sick with an infection that maybe they had a perforation of their bowel, or some kind of horrible infection would require this strength, this kind of antibiotic. Our prototype is imipenem. We're trying to protect this antibiotic because there has been a few instances of carbapenem resistant enterococcus, which is bad because this is the biggest and strongest antibiotic we have. There's nothing above it to give to a person who's resistant. So if that occurs, which it has on several occasions, there's not much we can do for that patient. Imipenem is the prototype. We have to be careful again with IV incompatibilities and thrombophlebitis. Some of the GI symptoms can increase if the IV medicine is given too fast, but in general, when you're working, the pharmacist provides for you the rate of how fast the medication should go, which of course will be many of the medication questions, drug dosing questions, the math questions that you'll see on the exam. So you don't have to decide how fast you want an antibiotic to go. That's decided for you. The biggest extra risk for this medication is neurotoxicities like seizures. And the last medication in this overall pharmacologic class of destroying the cell wall in some way is vancomycin, which is its own group. The family of vancomycin only has one drug in it, which is vancomycin. The problem with this, oftentimes we can have, penicillins all end in cillin, cephalosporins all start with ceph. Vancomycin, there are other drugs that end with mycin, but they're in different families, and so they're not related. So just because you see mycin doesn't mean you can tell exactly which family the medicine is in, unfortunately. Because vancomycin is a cell wall synthesis medicine and there's only one drug in that class, and that's vancomycin. It is a very good choice against resistant infections. So say that if someone has MRSA, which is methicillin-resistant staph infections, meaning their infections are resistant to penicillin, vancomycin is a great alternative for that type of infection. If you give it orally, it does not absorb, it stays within the bowel. So it is the gold standard treatment for C. diff. But when you give it IV, you can treat multiple types of resistant infections. Again, there's issues with incompatibilities and thrombophlebitis. This particular medication, we said if imipenem is given too fast, the patient might have more GI side effects. If vancomycin is given too fast, the patient can have this huge histamine reaction where they turn completely red and they can drop their blood pressure. So again, you don't have to calculate. You won't be told to figure out how fast to give it. The pharmacist will tell you this medication should be given over 60 minutes or this medication should be given over 90 minutes. But the reason why it's a longer period of time than others is because you want to be sure the patient doesn't experience that diffuse redness and flushing and low blood pressure. This is one of those medications that has, although it's very effective, its adverse effects are particularly bad, especially in terms of kidney function. So how do we know if someone has kidneys that aren't working? What kind of symptoms will they have?
Slower GFR.
Right, so they're not going to filter fluid anymore. So we could see that on a blood test, usually with BU and creatinine, but GFR is also listed on that blood panel. That's actually more sensitive. So if the fluid isn't being filtered, what are some of the symptoms we'll see with the fluid being stuck? Not necessarily urinary issues. I don't know exactly what you mean by that, Beth, but if you mean like it hurts to pee or something like that, or hesitancy, it's not like that. There'll probably be a decrease in urine output. Yes. Because less is just like, I believe that was Eric who said that there's decreased filtration. So where is the fluid? Right. It could be dependent on the extremities. So the person might notice edema in their ankles and feet. It could be in their lungs. They might have to be short of breath. They're coughing. And their weight will go up. That's the most sensitive indicator of fluid status, is the weight. So, the person who's getting IV vancomycin is going to be in the hospital, and these are things that the nurse taking care of the patient will be monitoring. Ototoxicity means it's damaging the ear, so that can be decreased hearing, but also changes in balance because the balance centers are also located in the inner ear. This is one of those medications that must be monitored closely. The pharmacist or the provider will do something called pharmacokinetics, and what they're trying to do is watch what the trough levels are. So if I give a medication, and I want it, I'm dosing it so it stays within this window. I will be, maybe for vancomycin, it has a longer half-life. Sometimes it's dosed 24 hours a day, every 24 hours, sometimes it's dosed twice a day. The patient hopefully will be in that therapeutic index. So if this is dose 1 and this is dose 2 and this is dose 3, at some point, as the patient's been getting the medication, the pharmacist or the provider will order a vanco trough. And the trough is supposed to represent the lowest, the amount that the of lowest blood concentration of the medication. And the trough should be measured right before the next dose. So the rule, we talked about this the first class, the rule is that the ideal situation is the person would draw the Vanco trough and you would then hang the medication. You do get a 30-minute window, but that's the ideal. So the pharmacist says, okay, I want you to draw a trough before you give the third dose. So one of your jobs as a nurse would be to be sure the lab has come and taken that blood test if it's not you that's supposed to draw it, and then that the medication is hung within the correct time period. And then you're going to hang the medication. You're not going to wait for the results. Oftentimes they don't come back right away. If the result shows that the level is high or towards or over the therapeutic window, what do you think will happen? How will the dosing be changed? Correct. Sometimes they will skip a dose or hold a dose, or they'll decrease the medication, they'll do something. Sometimes they'll do the trough and it's low, then obviously they will have to increase the dose of the medicine because you want it to stay within this window at all times. Too little, then the patient isn't getting the effect of the medication and their infection will get worse. Too high, and then the patient is more likely to suffer the toxicities, and especially the kidney toxicities. And they can result in permanent kidney damage or sometimes temporary dialysis or permanent dialysis. I've seen both. So people are usually very cautious when using vancomycin. So that is important. You don't have to memorize the range or what the vancomycin trough should be. It is actually very individual. It's based on the patient's size, weight, sex, but you do have to know if it's there, what does the trough mean, when should that level be drawn, and what would potentially happen if the trough level is too high or too low. So I just want to be sure everyone understands that. Before we continue. Okay. So we'll talk about a couple more drugs here and then we'll take a little break. Maybe we'll talk about the next family and then we'll take a break. So now we're headed towards, we talked about all the different medication families within the mechanism of action of changing the cell wall. The next pharmacologic class or mechanism of action are drugs that prevent bacteria from synthesizing proteins. And if they're not able to do that, then they can't repair themselves, they can't get ready to divide, and they will die. So this is still an antibiotic. It'll still get rid of bacteria. It's just doing it in a different way. So the first family in this class is Tetracycline. The prototype medication is Doxycycline. You can't really use Tetracycline anymore because there's so much resistance. So these end helpfully enough with cycling, because there are others in this family like minocycline and stuff like that. So again, we have the GI symptoms and secondary infections like we always have. We always have to worry about allergies. We have a couple of extra things to worry about this in terms of administration and side and adverse effects. So you'll see on the top of the next slide that it is best to give this medication on an empty stomach 1 hour before or 2 hours after eating. I always like, again, to be sure that we are separating antibiotics from food. especially in this case with foods that contain calcium. So if I'm going to let the patient eat with the medicine, then I have to be sure that there's no calcium an hour before or 2 hours after. I'm sorry, they can take the medication, and they have to be careful about when they ingest calcium, because it could bind the medicine and then it won't work. The other thing is you don't want this given too close to bedtime because it could actually cause reflux and discomfort for the patient. So a couple extra administration rules besides our usual ones. Aren't you not supposed to take it with vitamins? Yes, but the most important thing, and there are a couple of antibiotics that we have to be sure we separate from multivitamins and things like calcium and magnesium. But there's for sure the dairy issue because the tetracyclines like to bind to calcium. They will bind to people's bones and teeth, and that's why we have some of the other adverse effects we have to worry about. And since we're talking about that, I'll mention the teeth thing. So any teeth that are developing below the gum line have the potential to be stained by tetracyclines. So when this should not be given to pregnant women, it doesn't disrupt the pregnancy at all, but it will discolor the baby's teeth. So it is avoided, and there's nothing you can do to get rid of it. It's not like you can do some kind of rinse or whitening procedure. It's like in the tooth itself. It's not just the outside. So there's nothing you can do to change the gray discoloration that they'll have, like a stripe across their teeth. So there's always a question about this, being sure that you are aware that these medications in this family should not be given to pregnant women or children under 8, because you're hoping that you don't want any of their forming teeth to be exposed to this medication. The other issue is liver toxicity. So if we're concerned that the patient has a liver problem, what is the blood test that we would check? LFTs, that's liver function tests. And specifically, let's see what Emily is typing.
I can't think of what it's called, but I feel like it starts with a C and it's got a K in it. Am I right? I remember it from like a PowerPoint before.
Oh, okay. So creatinine is for kidney function, and if you're thinking of CPK, that's for skeletal muscle.
Okay, that's what
that's what I was wondering. So LFTs are liver function tests, and that's specifically looking at the bilirubin level and those liver enzymes like ALT and AST, because those enzymes should not be present in the bloodstream. They would only be there if the liver cells are being damaged, and bilirubin shouldn't be present in the bloodstream because the liver is supposed to take care of bilirubin. So what kind of symptoms would the patient have if they're having liver damage? No, their urine might be dark though. So it wouldn't be blood, jaundice. It would be a darker... I'm sorry, what?
It's going to be jaundice?
Yes, jaundice. So their abdomen could be distended. They could have pain in their abdomen. They will be jaundice because the bilirubin will be in their skin. And then they're going to get rid of bilirubin in their urine and their stool. So their urine will be dark, but it's not blood, it's bilirubin. And their stool will be light. So that could be how the question is phrased. Like, patient is taking tetracyclines. How do I know? Is this what exam finding makes me concerned that they're having an adverse effect? You know, if there's something that has to do with liver toxicity, then that would be the answer. So you have to remember what those symptoms are. Photosensitivity means that it makes the person very sensitive to the sun. So they could burn easier. It doesn't matter what their melanin content is either. Anyone could burn. So they should stay out of the sunlight. If they have to be in it, be sure they're wearing sunblock. If they have clothes that are covering less exposure of skin, hats with wide brims. Those are the kind of things you should teach the patient. And then we just have 2 more medications in this grouping. So we'll finish those before we take a break. So the next family in the decreasing protein synthesis is macrolides, and our prototype is erythromycin and azithromycin. So the N215, but they are not related to vancomycin. They're completely different. Macrolide antibiotics are the best alternative for a patient who has an allergy to penicillin because we don't have to worry about cross allergy at all. The reason I mentioned both erythromycin and azithromycin is erythromycin was the first one to come out, but you often have to take it multiple times a day, so it's hard for people to be compliant, and it is the hardest on the stomach. If a medication has to be taken multiple times a day, what does that say about the medication's half-life? It's short, right. So we have to keep taking it in order to maintain the blood level. Azithromycin has a very long-acting is a very long-acting medication. It has a very long half-life. So this is one of those medications that we have to give a loading dose in order to get into the therapeutic window faster, because otherwise it takes 4 half-lives to get into steady state. When I use a loading dose, I can get into steady state faster. So azithromycin, which is the Z-Pak, which a lot of people are familiar with, the first day you take 500 milligrams, the next 4 days you would take 250 milligrams. The lower doses, that's the usual dose. It's not really a low dose, it's the usual dose of the medication. The first day I took more than usual as a loading dose in order to get into the therapeutic window. There are some drug interactions. This is one of those medications that we have to worry about. Grapefruit juice. Does anyone remember the cardiac medications that we had to worry about grapefruit juice? Yep, nifedipine is one. Dun, dun, dun. I don't know if you're too tired to guess, but if you didn't know off the top of your head kind of fast, it might be an indication that you need to study a little more. Let's see what Maya has to say. I don't know if you notice this, but your name is like over and over again. Maisha Becker, Maisha Becker, Maisha Becker. Statins, yep, atorvastatin. Also had to be careful about grapefruit juice. Giving Justine a chance. You can say it too. No. It was. The other is amiodarone. So I like to do this now and again, as we're learning new content, to try to remind you about old content, because remember oh, the final exam is cumulative, so we have to remember that content. You still have to look at it every now and again, because you don't want the end of the semester to be as brutal. Not that you have tons of time because you have to learn this new content too, but we still have to remember that a little bit. And feel free to talk. You know, it's nice to hear other people's voices. Oh, Beth has a question about going over your exam. Yes, send an email, and then we can work it out that way. Okay. All right. So, other issues with macrolides. Again, we have to worry about GI stuff, allergies, secondary infections, extra toxicities. For this one, again, is ototoxicity, just like vancomycin, that we had to worry about damage to hearing and balance. The other is cardiac toxicity. This medication causes a particular arrhythmia called a QT, a prolonged QT, which can set the patient up for a type of VFib. So we have to be careful. There are other medications that can prolong the QT. So if the person is taking multiple of those medications, they're definitely at increased risk. So that would be the worry for that one. And then this last medication before we take our break. So again, we're still altering protein synthesis. This last family is aminoglycosides.
I just had a question on the previous slide. You had on there, yeah, secondary infections. What's that?
Oh, that's the same as those super infections, like
okay.
fungal infections or C. diff.
Okay, thank you.
Sure. Okay, so gentamicin. There are other ways we can give gentamicin, which you'll sometimes see as for topical reasons, like eye drops, ear drops. Usually, if gentamicin is given IV, it's reserved for very serious infections and in the hospitalized patient. This is another medication that generally has a narrow range. And it has multiple incompatibilities. It's similar, even though they're in different classes, it's similar to vancomycin in that it causes ototoxicity and renal toxicity. Vancomycin is biggest risk is renal toxicity. Gentamicin could do either, but the biggest risk is ototoxicity. So this is again another medication where peak and trough levels are important. It's usually trough levels that are ordered. Okay, so at this point we will take a break until 2 o'clock. So I'm going to come off this call and I will reconvene at 2. I will restart recording here. Okay, so let me share my screen again. We have now come to the third pharmacologic class of medications that fight bacteria or antibiotics. This pharmacologic class just has one family, which is fluoroquinolones. The way this works is this medication inhibits DNA replication, so then the bacteria can't divide and keep living. So fluoroquinolones is our family. Cephalosporins is our prototype medication. Very good medicine that has a wide, broad range of action. We still have the same GI stuff, allergies, possible secondary infections. Fluoroquinolones, especially Cipro, is notorious for C. diff infections, so to be very careful. Some extra issues. This is another one where you have to be careful about antacids and calcium, as it may bind the medication and make it less effective. We have to worry about photosensitivity, just like the tetracyclines. This makes the patient more sun sensitive and they can burn. For elderly people, it can cause a headache and mild confusion. There can be some insomnia with this medicine to begin with, and so if you drink caffeine, that can increase those chances. The other weird thing that can happen with the fluoroquinolones or ciprofloxacin is something called Achilles tendon rupture. Well, for some reason, medications in this family can cause an increase in water absorption into tendons. And this can start to cause pain in the tendons or eventually pull them so much that they actually can tear. And if you rupture or tear your Achilles tendon, that's a very long rehab. You probably are out for at least a year. You have to have surgery, and the rehab itself is pretty difficult. The Achilles tendon and the tendons around the knees are the most prone to this injury. If the patient developed that, then they should call you right away and switch medications. And they should probably never take medications from this class again. Yeah, I noticed that too. I think there might be someone with their mic on. There's a little bit of feedback. It might be you, Beth. I don't see the little mute thing.
Oh, I'm sorry.
It's okay. It looks like we lost somebody too. Let's see. That's always sad. Who did we lose? Say Nicole, Keisha, Emily, Leah, Stephanie. I know Brian and Caleb are together. Cindy, Beth, Janice, Lisa, Eric. I think we lost Stephanie. Oh, no, she's here. Where's Nicole? I don't know. I'll have to watch the tape and see who dropped off. Oh, maybe they're back because I see 13 now instead of 12. I was sad because that makes me sad. Very, very fragile. Okay. Last but not least, family of medications. So this is the last pharmacologic class of antibiotics, which is inhibition of folic acid. So by inhibiting folic acid, the cell cannot create an extra copy of DNA, and it won't be able to divide. We talked about another medication that inhibits folic acid. Does anyone remember what medicine that was? I think it was you, Mai, that I didn't have, but now I see you're here, so. Does anyone remember the medication we talked about in the first unit for exam 1 that also inhibited folic acid? Ryan, that was so long. It doesn't feel like 10 years ago. It is methotrexate. That's correct. Scott gets the gold star for the day. Okay, well, the other medication that we'll talk about that does that is sulfonamides, which is Vactrum. Well, I would have been there you go. So, sulfamethoxazole and trimethoprim are Vactrum, and that's the prototype sulfonamide that we'll talk about. Sulfamethoxazole is the actual antibiotic. That's the actual ingredient. Trimethoprim is added to help decrease resistance, just like clavulanic acid or clavulanate was added to amoxicillin to decrease resistance. So, medication should be taken with a full glass of water. We're hoping that the person can take it on an empty stomach. Since this medication works similar to methotrexate, there's a risk of increased immunosuppression when taken with methotrexate, so usually they aren't taken together. This is similar to penicillin in that if the patient is on oral contraceptives, it will decrease the effectiveness of oral contraceptives and the patient could get pregnant. Similar to the cephalosporins in that there's a risk of the disulfiram reaction with alcohol, so the patient will have a headache, nausea, vomiting, and potentially decreased blood pressure. We have to worry about allergies, we have to worry about GI symptoms, we have to worry about super infections. Those are the things, or secondary infections, those are the things we worry about all the time. The other issue is Stevens-Johnson syndrome, not to be confused with toxic epidermal necrosis. So what are the symptoms of Stevens-Johnson syndrome?
Starts off with a rash
Right.
on the chest, more specifically.
Correct. And so usually the other issue is that that's associated with it is upper respiratory infection. So oftentimes sulfonamides are prescribed for UTIs. The patient has that infection, they're taking the medicine, all of a sudden they feel like they have like a sore throat, kind of a cold of some kind, and then they get, just like you're saying, and what Aaliyah has here too, is that they get a rash that looks like blisters primarily in the chest and torso, which is different than toxic epidermal necrosis, which is when the epidermis, or that top layer of the skin and mucous membranes, dies, and then that's when the skin sloughs off. The other issue is bone marrow suppression. Even if it's not taken with methotrexate, we have to worry about bone marrow suppression. So what cells are made in the bone marrow? Well, we need those cells. That's a part of bone maintenance, more in the actual bone tissue.
Blood cells?
Right. So what kind? White blood cells are one kind.
Is it
Red
red?
blood cells, white blood cells.
Red blood
One
cells?
more kind. Yep. And platelets. White blood cells, red blood cells, and platelets. So then, if the patient is on this medication and they complain of being tired, or they're bleeding easier or something like that, then we might worry that there's a problem with their bone marrow itself. And that's what bone marrow suppression means, that there's decreased growth of all the types of cells that are made in the bone marrow, which includes red blood cells, white blood cells, and platelets. Okay, and this last medication we're not going to worry about. I'm crossing that out. It's always fun to cross out things that you don't need to worry about. Okay. So the next groups of medications, we're going to have to talk about medications that help kill parasites and medications that are directed towards tuberculosis. Those decks of slides, those packets of slides are much, much shorter than the ones we just did for antibiotics. So which is good, because that antibiotic one is a killer. Okay, let us get to those. So medications for tuberculosis. So who can tell me what someone with tuberculosis, what kind of symptoms they have?
Spitting up blood, like with their cough.
Yeah, so it's the fever. I see Emily says night sweats, and the cough is productive. It's usually blood tinged or bloody because of the amount of inflammation. Tuberculosis is an airborne mycobacteria, so it passes in the air, and the tuberculosis, the infection, can actually travel 10 to 15 feet from the patient. So they're very infectious when they have an active tuberculosis And that's why they need to be in those negative pressure rooms. We got to pull the air away from the people that aren't infected. Mycobacteria, like tuberculosis, are extremely hard to kill, and they create part of the reason we have the symptoms we do when we have tuberculosis infection is the fact that the mycobacterium is there creates this over exuberant response of our immune system, almost like a hypersensitivity reaction to this mycobacterium. It really revs up the immune system. So that's partially why the person has a lot of sweats and fevers, and because of the inflammation that's going on, where they get the bloody cough. And the reason is because mycobacteria have this waxy coating that makes it hard for our body to get rid of. Sometimes what will happen is our body will try very hard to get rid of it, and instead of completely getting rid of it, this is the person's lungs. Yes, I realize that is a bad drawing. Here's their heart. If they have an infection with tuberculosis, sometimes instead of clearing the infection, the body will just wall it off. So the person won't have symptoms of an active infection. They won't have a fever. They won't, they won't be coughing up with the bloody sputum. They won't have the sweats. And in fact, they couldn't give you the infection because it's not an active infection. However, if that person would become sick, that infection could reawaken. So we do need to get rid of it. That's the reason to do the tuberculosis testing procedures, because you want to find the people who have a potential infection, potential latent infection, so that you can treat it to prevent them from getting sick. Because if that reawakened, they could also infect the people that they're nearby. So this tuberculosis infection causes a huge reaction. The body really gets revved up to try to get rid of it. Active treatment and latent treatment is what we have to deal with. Active treatment, the course of treatment is very patient specific. It depends on when their sputum is free of the tuberculosis and when their chest x-ray clears. So the treatment can be long or short depending on the person. Treatment for latent TB, the person that has that walled off infection that's not an active infection, will take 6 to 9 months, and it depends on what their chest x-ray looks like. If the person has a latent infection, meaning it's not active, they only take one medication. They take isoniazid. If the person has an active infection, they have to take more than one medication, and it's usually isoniazid with rifampin or one of these other medications. Our prototypes and the ones that we're going to focus on are isoniazid and rifampin as the active treatment. There's sometimes a question on the exam, why would someone need to be on more than one drug when being treated for active tuberculosis? The reason is to prevent resistance. So keep that in mind. Oftentimes when people are on multi-drug regimens, that's what the goal is to prevent resistance. And that's why people do that with tuberculosis. Medications for tuberculosis are hard on the patient and will require frequent monitoring. So you could give isoniazid by itself in the latent disease for 6 to 9 months, or given with another drug. For us, it would be rifampin for active disease. It's generally given oral. Try to separate it from antacids and magnesium, and meals if able. This is another example of a disulfiram reaction, meaning it's similar to alcohol, so the patient could experience nausea, vomiting, headache, and potential low blood pressure. This is important because active tuberculosis infections are often associated or can be common in the patients with alcohol issues, so we have to be careful. It can lead to being on isoniazid for a longer period of time, which you're going to have to be on it for months, could increase your risk for hepatotoxicity. So we just talked about that. That's the damage to the liver. So it would be the liver function tests, liver enzymes, and bilirubin that we would be checking periodically on this patient. We would want to know if they were having abdominal distension or pain, jaundice, dark urine, or light stools. The other issue is CNS effects, especially when combined with alcohol, which we know we don't want to do because there's a disulfiram reaction. But our neurologic symptoms, like seizures and peripheral neuropathy, increase if the patient is drinking. The medication that we would use as part of active treatment with isoniazid is rifampin. It is an adjunct tuberculosis treatment. It does have other uses, but most of the time, currently it's used for tuberculosis. This is another medication that should be separated from meals. Similar with the GI effects can be severe, so we try to separate it from meals, but sometimes people can't. We have to worry about liver toxicity just like we had to with isoniazid. A unique thing about rifampin, which is not dangerous, but the patient should be taught about, so this is always a test question, is that it can stain body fluids with a red orangish color. So the patient will notice a change in the color of their urine. It's not blood, and it will be difficult to distinguish it from extra bilirubin in their urine. It's like a reddish, orangish hue to urine. It could be orange in their stool. Their sweat will be orange, so they're going to have to be careful about what sheets they use because that could get stained. Their tears can get this color to them, so they could stain their contacts. So you have to be sure that people are aware of this because that could be kind of scary. And one other concern with all medications for tuberculosis is it can cause this very specific drug reaction called DRESS, which is drug reaction with eosinophilia and systemic symptoms, which essentially means there's too much eosinophils, kind of like an allergy. So the patient has not just facial swelling that sometimes people can see with an allergy, but also inflammation to other organs. And their faces can sometimes look like these very inflamed faces. So that is the medications about tuberculosis. Any questions before we go on to parasites, which will be our last group of material for today? Okay, looks like we're good with tuberculosis. So moving on, or I've just killed you. Moving on is medications for infections that are caused by parasites. So parasites are single-celled organisms. They can live in different areas of the body, in our GI tract, in our red blood cells, and other structures. They need an animal host in order to survive. Parasites do, so they need you to live. They are found in contaminated water or soil, which is sometimes how these infections start. Two common types of parasitic infections are GI type infections like Giardia, or STI GU infections like trichomoniasis. So those are what they would look like under the microscope. They're actually organisms, not just much more complex than a bacteria cell. And so we can use the medication metronidazole, which is Flagyl, to get rid of these types of parasitic infections. So metronidazole is an antibiotic. It can also be used for other infections. It has really good coverage for things like for your teeth and, yeah, ew. Good coverage for tooth infections. It used to be the standard treatment for C. diff, but doesn't work as good anymore because of resistance. So you'll see it used for other infections, but it is a really good treatment for parasitic infections, which is why we talk about it with this. It enters the organism and damages the DNA. It comes in multiple forms depending on where the issue is. IV, tablets, creams. It's best to take without food, but again, you could take it with food or milk. There's no calcium interaction with this one. This is another medication that has that disulfiram reaction. So far, the disulfiram reactions, I think, were cephalosporins, Tetracycline, metronidazole, and isoniazid. That's a good thing to keep in mind. Issues that we could see with this medication can sometimes change the person's appetite. It is notorious for, at the time that the patient is taking the medication, to cause a metallic taste inside their mouth, which is really unpleasant. Tastes like the patient is sucking on a penny. So they should know that that's possible, and it'll go away when they're finished with the treatment. The biggest toxicity issue is neurologic. Could be headaches, vertigo, which is like the room is spinning. Ataxia is imbalance when you're trying to walk. And seizures, sometimes people notice that their urine is darker, but that's harmless and that'll go away. The other type of parasitic infection that we talk about is malaria. So malaria is a mosquito-borne illness. The parasite has a nice relationship with mosquitoes. So mosquitoes can accidentally deposit the parasite into a human host when biting that person. Certain areas of the world where malaria is endemic, especially near the equator where the warmer tropical weather. The way that malaria affects the body is that parasite enters your red blood cell and uses the person's red blood cell to divide itself. And after a period of time, then the red blood cell will burst, releasing all the parasite into the bloodstream, and then causing anemia because it's destroyed that red blood cell. And then the parasite can find other red blood cells to complex with and divide. So the patient can become quite sick. If a person is traveling, so that's obviously not a disease that is common in the United States. If a person is traveling to a country where malaria is endemic, then they should be treated with prophylactic anti-malaria drug to try to prevent the infection from happening. And the prophylaxis is 500 milligrams per week, starting 1 to 2 weeks before the person leaves, the entire time that they're there, and then weekly for 4 weeks after they return, to prevent it. The way that chloroquine works, chloroquine is an anti-malaria agent. We talked about it before because the other way it's marketed is hydroxychloroquine, which is used as a anti-inflammatory medication for people with rheumatoid arthritis. So those are people that are going to take a different dose daily to manage the inflammation from their rheumatoid arthritis. This medication, marketed as chloroquine, it's the same thing, but it's slightly different treatment for a shorter period of time for the infection brought on by the parasite that causes malaria. the way the medication works is it's a heme complexing medicine, so it sort of blocks the red blood cells so the parasite can never get inside. So the parasite might get inside the patient's bloodstream, but if it's never able to go inside a red blood cell and then divide, the patient will be fine. Or if the patient already has the infection, it will protect the rest of the red blood cells, and eventually the infection will go away. So this is try to separate from food if possible, and especially antacids can be given PO or IV. We talked about the two issues. One thing isn't listed here is cardiac toxicity. So the person with malaria who actually needs treatment is pretty sick, especially in the beginning, so they'll be monitored in the hospital. This vision changes that we talked about with hydroxychloroquine is an issue, but not as much so for these people because they're not going to be on it as long. People who take hydroxychloroquine for rheumatoid arthritis are the ones that have to see the eye doctor every 6 months to check for retinal damage. You want to find that before it becomes permanent and they have permanent vision loss. So it's not as bad or as of an issue, this vision changes, as it is if they're taking it every day for the rest of their lives. So this section actually finished a little earlier. Does anyone have any questions? Because that's the material that we have for today. Remember to do the infection ATI prior to class, because there is a quiz that will be done in the beginning of class on that first group of slides.
I guess I got a question on hydroxychloroquine versus chloroquine. Is there one that usually tends to have more adverse reactions when it's administered?
It's usually
I guess one that has more consistent adverse reactions.
It's usually hydroxychloroquine because of the amount of time that the patient has to take it. People on chloroquine just feel sick in general because they have malaria, so it's hard to tell. There are some people that will have an increase in anemia in the very beginning, but usually it's the people on hydrochloroquine that will have more trouble. I'm sorry, Lakeisha. I will keep trying to do that ahead of time. I have to update some of these slides, so that's kind of delayed it a little bit for me, but I will try to do that for you. Just responding to Lakeisha. Sure. And then if you wanted to go over the exam, then just send me an email and we can make an appointment. This was recording, so I will process this and give you a link so that you can listen to it again if you need to. And just don't forget to do that ATI so you can take the quiz. All right, you guys have a good rest of the week.